talk loud.
Thank you, everybody, for being here. We'll get started. This is, as everybody knows, to make sure you're in the right place, both payer and payer services. My name is Deborah Gordon. I'm an attorney at Seyfarth Shaw. I do a lot of work in both healthcare regulatory work and healthcare M&A and finance work. And we have a really great panel for you today. We have Craig Ikens, who is the Senior Director of Corporate Transactions and Business Analysis at Healthcare Service Corporation. This is the fourth largest insurer in the United States, and they run the Blue Cross and Blue Shield healthcare plans in Illinois, Texas, Oklahoma, and New Mexico. And Craig is responsible for their mergers and acquisitions and joint venture work. We have Gary Velasquez. He's the Managing Director at Tricium Healthcare Partners. He has over 30 years of experience in life sciences, managed care, and specialty healthcare sectors. They are a knowledge process outsourcer and specialize in providing clinical management solutions. And we have Tom Wiffler, who is the President and CEO of UnitedHealthcare of Illinois. And they are part of UnitedHealthcare Group, which is the largest single healthcare carrier in the United States. UnitedHealthcare of Illinois serves over 1.2 million people in Illinois and contracts with over 22,000 physicians and 150 hospitals. So welcome to our panel. We're hoping for a really fun, lively, and interesting discussion on where the market is going. We're going to have each of the panelists just spend a minute telling you a little bit about their role in the healthcare market and the things that they're doing, and then we're going to do some questions for the panel and then open it up to the audience. So Craig, do you want us to get started?
Sure, thanks. Craig Ikens, I'm Senior Director for Corporate Transactions at HCSC. As you mentioned, we insure about 13 million members in our 4 states and kind of across the country, as we have a very large national account presence. I've been with HCSC about 5.5 years, and during that time overseeing our merger and acquisition activity, and so my team's responsible for everything from due diligence to business case development to negotiations on the deal as well.
I guess good afternoon now, right? Not good morning. Yeah.
No, it's morning.
Good morning. Huh? Good morning, thanks. Yeah. I'm Gary Velasquez. I've been in healthcare about 30 years. I was the magical 13th employee with Pacific Care in 1979. And so I've been around, that long. And then I left there to join HealthNet, and I got to see, lead. It's pretty funny to see HealthNet get into the care delivery business. So I was the guy who bought 25 clinics in 3 hospitals, and I was the guy to sell 25 clinics in 3 hospitals. And left there and became a partner at a private equity firm. And I was there a whopping 6 weeks, and they asked me to run one of their clinical research organizations. And I said, I'm from the other side of healthcare, the dark side, not the R&D side. And they said, you'll figure it out. So I had the pleasure of running a global CRO for about 5 years. And now I'm running a knowledge process outsourcer with about 400 or 500 nurses in Manila. And so from a case management, utilization management, coding, documentation on the provider side primarily.
Thanks, Gary. My name is Tom Wiffler, President and CEO of UnitedHealthcare of Illinois. My role is trying to justify that I'm not overhead on a daily basis. We do that with providing benefits to individuals and employer groups of all sizes, from 2 members up through jumbo national accounts. We have about 4,500 employees in the state. I've been with United about 13 years, so I've seen us grow from a kind of a disparate regional player to a large, very 50-state covered national player, much of that through acquisition across the spectrum of the country, both in size and capability. So looking forward to getting started here, and pleasure to be here.
All right. Well, the first question I have for our panel is, we heard a little bit about this morning about what is the current market and the future market for exchanges. And I think the congressman sort of predicted that, one element may be the future of really just almost creating a single sort of pair market. But I'd be interested in our panelists' view on both what the market is for exchanges, what you think the future is going to look like, and both on public and private exchanges.
I told my colleague from Aetna I was sitting with during that hearing, Congressman Stupak, I said, we got 10 years before we need to retire, I think, apparently. But, for HCSC, as we look at exchanges, I think we see that being a very active opportunity for us, both from a standpoint of the public exchanges, but then also on the private exchanges. Last year, actually, we, along with WellPoint and the Blue Cross Blue Shield plan in Michigan, bought a company called Bloom Health, which focuses, is a private exchange solution to offer to employers. That we saw that the movement to define contribution for employer groups really becoming kind of a next big wave, with sort of a similar trend to what you saw 15, 20 years ago with the movement for retiree and retirement benefits from pensions to 401ks and moving those to defined contribution. So we looked at that and said that there's a real market opportunity. We think there's a lot of growth that's going to be driven in that space, especially in the retiree space where you've already got guaranteed issue and no concerns there. But even in the active space, there's a lot of activity right now. State Farm, for example, is one account that's moving all their retirees to this type of model. My parents are actually HCSC members, even though they live in Michigan, and are going to move to this type of model if Aon Hewitt can never fix their implementation issues. On the public side, though, obviously, there's a little bit of uncertainty about what's going to happen in the next few months. I think everybody's kind of hoping to get sorted out soon so we know what the playing field is. But I think we look at that and figure that there's going to be something that's going to move forward on that no matter what.
Sure. The exchanges, I don't think we share the same view of the 10-year horizon, so Craig and I agree. So we have to get going on the retirement plan if we're going to do that. But and I say that because if you look at the studies that have been done, albeit in the last couple of years, on employers' appetite to abandon their coverage models and push their employees out to exchanges, you see single-digit adoption into that on a base of about 140 to 160 million members in the current employer-based model. So while that could be a big, couple of million to maybe 6 million people, that's not really a seismic shift in the way that the industry is currently configured and the way that the this delivery system is set up. So, and the financing system. So, exchanges are a reality. There are some that are already up and running, as Craig mentioned. We have our own version, a company called Connections that we purchased out of Florida, and it's really going to provide the platform for us to compete in that space. The exchange at the state levels, which is something we have to keep our eyes on, is and for those who are Illinois residents, you will readily appreciate that we aren't ready yet. Our enabling legislation in the state is weak right now, and the thing to watch for is whether or not the state decides if it's going to be an active purchaser, where we collectively would compete with a government offering, or simply a market facilitator, which is from a market person's view, that's probably a more preferable model. But we don't know what that's going to look like yet. But there's a recognition that there will be some migration. I don't think anybody has put pen to paper to say that it's going to be sort of a herd mentality.
I guess I would comment saying, stepping back from exchanges, I'm more kind of a systems thinker. What problems are you trying to solve? I think I hear kind of an allusion or a illustration in your voice. They're not going to be the be-all, end-all from United's perspective. And so if you think they're trying to solve three fundamental problems, fragmentation, affordable care, and fix the reimbursement methodology, I think there's other models and other learnings that we need to bring to the equation that you have as payers, because we've all climbed that hill in the last 20, 30 years, that can bring to the exchanges. So I think we have to step back and not just run to exchanges as another rubric to solve the problem. I think it's fundamentally what are the problems you're trying to solve.
Well, that sort of leads us to, it's like a good transition topic, Gary. If you don't mind, maybe taking one of them in terms of, maybe payment and payment structures, and maybe if we could talk about that. And certainly we've heard a lot about, quality payments and pay for performance types of structures and changing the payment methodology. If you don't mind sort of picking up on that and bringing
Sure.
that to the panel, if you don't want to start us off and sort of what you see and your viewpoints on that.
Sure. So the last company I was running after the Sierra was in the HEDIS and HCC collection space. So we, on behalf of United, one of our customers, went into the clinics, hospitals, physicians' offices, and pulled the charts. We pull 3 million charts a year. Yeah, you're smiling at me, yeah. And we extract this clinical information all under the guise of improving quality scores and rubric. And United's not in this case. But I really didn't see us and the work we're doing in collecting the quality, reporting the HEDIS scores, the STAR scores, really improving quality, because we're doing it retrospectively. We're doing it in some cases a year after the fact. And so how can you affect a clinical event a year post? You can't. And so I think one of the fundamental challenges, again, what's the issue you're trying to solve? I think STAR scores really were intended and are intended to basically weed out the bottom third of the non-performing health plans. I think if you actually sit down with Congress, that was the intent. Now, I think there's a way to improve quality, but it's some of the technology solutions that have been talked about and getting that at the point of care versus chasing medical charts or reporting things a year after the fact. I don't think that, in my opinion, has a demonstrable effect on quality. And I think that's supported by the GAO finding.
That's right. Craig or Tom, do you have any comments on?
Sure. Chasing quality is a never-ending pursuit. We see the STAR rankings is I would agree that it's trying to identify that left side of the curve and push everybody to the right. And as healthcare folks, we always reference the article that was done now almost 10 years ago that said that about 50% of the care that's delivered is appropriate and produces the intended outcome. So we've got large upside around things like quality. It was mentioned in previous discussions this morning around the payment methodologies. Bundling type methodologies are going to get us into a new space. The fee-for-service kind of turnstile healthcare is not going to be the future. And once we I guess not once, but as we continue down that path, the new models around things like bundling and much more outcomes-based reimbursement will connect more deliberately the activities that drive outcomes instead of looking in the rearview mirror as we have done and said, "No, you got that right. You didn't get that one right. We'll split the difference." That's really becoming archaic almost as every day passes.
Do you see payers and insurers really driving, or even sometimes even on the employer side, really driving that?
Sure. Yeah, I'll keep going for a second. Okay. Larger employers, self-funded employers are demanding performance-based metrics in their contracts. It's not a nice to have anymore. Those are becoming table stakes. And each of our contracts with our hospitals are now active on renewal, and sometimes in mid-contract we're introducing mutually agreed upon performance metrics that we can measure and drive reimbursement through.
Okay.
It's interesting, Tom. I have a question for you, and I'll make an observation. So we do work with some large hospital systems, and they're wrestling right now with, well, I'll say integrating three things: charge, capture, I think we heard that in the panel before this, clinical documentation, and now they're being compelled to do case management. It's all things we solved, 15, 20 years ago. And to me, that's a wrestling with, especially if they're going to start to get bundled payments, or if you want to call them integrated fee-for-service payment, whatever you want to call them. Here's a package of dollars for that episode of care. I think some of that support of charge capture, linking to documentation, and then following back up with case management, all concurrent, they're all wrestling with. And so, I don't know how United or the Blues think about that and how they help tackle that problem.
Yeah, I think one of the things that we have to look at and are pretty heavily involved in right now is trying to figure out what are the technologies and other capabilities we have to help provide to enable those provider organizations and make them effective as they begin to take on risk and change the way that they're receiving dollars. So that's certainly one of the big spaces. With some of the companies, we've got about 35 different subsidiaries, and some of them have capabilities that play in that space that we're working through. And United obviously has Optum Health as their big entity. You're just sitting there saying, what is it? How do you really make that provider take on the new world of responsibility and move that forward. And so we're pretty actively looking at, how do we help manage that? We've got, for HCSC, we've got a pretty extensive relationship for an ACO now with Advocate Healthcare here in the Chicago market that's, charging forward. And that's, kind of becoming table stakes for, how we begin to interact with a lot of our provider organizations. I mean, we've had a couple of them that have come back and said, they just want to continue to be sort of, fee for service and not have any changes and put any risk on the table. And, I think we sort of look at that right now and say, these are, sort of dinosaurs in denial about what's going on right now.
Well, in that regard, with just following up on what you said, Craig, in terms of the provider consolidation and the ACO market, this is obviously, somewhat reminiscent of, previous trends, let's say in the 90s, where there's a lot of provider consolidation and as well as sort of capitation payments. So what's different about this market, and how are payers sort of somewhat driving that or working within this consolidation trend to really kind of focus on these bundle payments, outcomes driven, and how is it different sort of in this market than it was in the 90s?
Let's see, having started in healthcare in the 1998, I'll qualify it a little bit, but
Apparently I'm dating myself.
but I would say, you just look at the global trends. I mean, go back to what we heard this morning from the guy from the Marwood Group, and where we're at with the costs on healthcare, and I think everybody looks and says that this thing's broken, and we're wasting a lot on unnecessary care. And there's a lot that needs to be addressed. And the change in, the cost structure just can't continue at the level that's going when it's so outstripping inflation and wage inflation that you've got to have these changes come through. I mean, as I said, employers are demanding it today. As an insurer, we're certainly, pushing and demanding it as well. That there's got to be a change in where that risk falls. It may not shift 100% over to the provider organizations. I mean, there might be some, hybrid models in there, but there's got to be a change in how that reimbursement proceeds.
And then Gary, from your perspective on
Sure.
the sort of the clinical management or case management, I guess what's your perspective on that?
So, let me put on my HealthNet Foundation Health
Okay.
hat and why, we needed to be in the care delivery business. It was pure market response. We were getting our market share eaten by Kaiser. And we said, okay, how do we compete against Kaiser in California? Guess what? We need to be in the care delivery business. So we went out and spent almost $1 billion acquiring hospitals and clinics and IPAs. And that was the driver there. I think what's different now, the world's largest payer is involved in driving this. It's not us, HealthNet, competing against Kaiser here in California. It's the world's largest payers pushing this. And I think that's a fundamental game changer as I think about what we tried to do in the 90s to where it's at today.
Okay, Tom, any perspective on your end?
The ACO model is, I think, needs to be put in the context of there are a number of models that we as an industry, I think we sometimes are moths to a flame on. Everybody's talking about ACOs right now, and the definition of them varies pretty much at the individual level. It's an aspirational goal. There are pilots within United running around the country. We take an approach of trying to be very thoughtful on how we put them together and how we collaborate with the provider and the employer market. And I think the jury is still out on whether these are going to be the next solution. But they are something that needs to be worked on and tried, and place some bets there and see if they can pay off. And because the fundamentals of the health of this country are going in the wrong direction. I mean, we've got problems that we're not even talking about. We've got kindergartners, 1 in 4 kindergartners are obese now. 30 years ago, it was 1 in 20. 40 years ago, it was 1 in 50. So 15 years from now, if we still exist, you're going to have employees coming to the workforce with comorbidities that we've never faced as a nation, and it's that 600, 800-pound elephant in the room that we don't want to talk about. But the vehicles to solve some of those problems are going to come out of things like ACOs and patient-centered medical homes and any other acronyms that we could create. But it's that collaborative, looking at the problem the same, or seeing it as what it is and developing some solutions around it. And some of them aren't going to work, but we can't stop trying.
Well, Tom, that kind of leads to, another topic in terms of wellness care and preventative care. And, what sort of the current market is on that, on the payer side, and what you see the future of that is, and where the driving forces of that are coming from?
It works. It's wellness, building an awareness and a culture of wellness inside of a company works, but it doesn't happen overnight. We have an example in our market here of a Southside manufacturing firm 10 years ago appeared to be almost as a requirement that you had to smoke to work there. The CEO himself demanded that we provide some kind of solution for him to make his 60th attempt to quit. We built a solution around that. He socialized it through his company. There's about 1,000 employees, and he created an incentive program that incrementally built upon the stones that were laid in the beginning, and has nearly eradicated smoking from his company. The most important part of that is he took annualized medical trends from somewhere around 13-14% to flat, and in the last 2 years, they're actually negative. And it's really built around some of the fundamentals of what we call now wellness programming. And it can work. We've seen it. That's one example among many. I know the Blues have a similar solution and experience with that. There's just been a reluctance within the employers to really push it hard and really kind of double down on some of the techniques to get it done.
And do you see it when it's successful being really driven on the employer side?
It starts, I think, a tight, high correlation between the adoption and sponsorship of the program within the C-suite or ownership group and the success of the program. If it's just outsourced to a benefits manager or a VP of HR who do great work, then notwithstanding their great work, the program doesn't really get the legs it needs.
Yeah, I'd echo those thoughts. I mean, we certainly see, it's funny because everybody, you talk to the wellness vendor and they say, guaranteed ROI, right? And they've, got these great studies, but, I think most people would say there's still not great evidence out there. But fundamentally, employers are doing this. I mean, what we're seeing, where we have national account groups that, pay $40, per member for things like UM and CM, they're out there right now starting to spend $100 to $600, to do wellness programs. They're implementing competitions within their organization that have gained a lot of traction. The smoking ones, it's certainly something like for us as an employer at HCSC, for example, now we charge a premium for anybody that's a smoker. What we're also seeing in the marketplace is that you begin to push that out beyond just smoking as a particular issue, and now it's going to be things like that on obesity is such a critical huge issue for us as a society to address, that's going to begin to be something where there's going to be penalties associated with not so much whether or not you are at a point where your BMI is above a certain level, but if it's above that certain level and you aren't engaging in a nutrition program that the employer offers or into a weight loss program, then there's going to be penalties for non-participation in that's coming along, and that's something that I think that's gaining momentum. I mean, you look at the costs associated with that particular issue and all the long-term issues associated. I mean, it's a major sort of crisis that's coming along.
Gary, Gary, do you see that as well? So on the preventive side or in the case management area?
Yeah, the concept I think in economic terms is I think called free rider. I can get insurance, but I'm healthy, so why do I have to pay for it? So that's kind of the inverse of the free rider. I think the key for these health programs is the incentives, as you alluded to. Have the incentives of the employees to become healthy and to stay healthy. If they're saying, just because of underwriting pool and we're all going to benefit from lower insurance premiums, it's too many standard deviations away from me. And so I think that individual incentive that comes, as you said, from the C-suite to become healthy and stay healthy is key in these wellness programs.
Okay. In terms of just kind of going back on the provider consolidation, do you see because of that consolidation trend, because of that ACO trend, do you see networks getting more narrow as a result of that, or just more narrow as you really try to drive quality initiatives that having a smaller network enables you as payers to really drive down that evidence-based care? Or do you see the demand on the opposite side for having a wider network or employers really wanting to have greater access to care?
I'll start on that one, I guess. We certainly see, I don't know how narrow they'll want to get, but I think certainly there's a willingness to look at narrower networks. I mean, HCSC has a very large HMO network here in Illinois. And the big thing is, especially with where the costs have been going, our HMO network versus our PPO network is probably anywhere from 10 to 20% lower in terms of the cost structure than what the others are, and with oftentimes we think actually a better quality mix than what's out there. For anybody that's from here in Chicago, and for somebody like me who has a couple kids, everybody I know wants to have their kids at Northwestern Hospital downtown here. But yet there's no understanding of the price and quality really compared to, for example, Advocate. And we'd look at it and say, listen, Advocate has just as good of outcomes at a dramatically lower price. When I'm in the room after delivery, I may not have a flat screen TV in front of me, but if I understood what the cost was and had some connection to that, I'd be saying I'm going to Advocate, I'm not going over to Northwestern, or they've got to at least begin to address that. So we certainly see on networks, that there's we've had a lot of success in that with our HMO network, and think that will continue. And, employers just have to do something to keep that cost under control, and that's going to certainly be one of their weapons.
Gary or Tom?
Just 10 years ago, if we went into a prospect office and asked or offered them a narrower network, the response would have been, I need every single hospital you can get me, and if one of them is out, we're probably not going to be moving our business to you. So access trumped cost probably 10 to 1. Today, it's almost completely flipped on its head. There is now an appetite to carve out and reduce the size of networks based on cost and quality. And so we find ourselves as the number 2 player in the market, emulating some of the things that the Blues do and creating some of our own packaging around network configurations, because there's a demand for it. The employers are now willing to do it, whereas they wouldn't even consider it 10 years ago. So I think you're going to see more of that. An example I had just a month ago with an owner of a company when we were delivering their renewal, he asked me and he pointed out his window, if the hospital across the street from his office could be his network. Could he make that his network for all of his employees and just make them go to there? That is a conversation that would have never taken place maybe even just 5 years ago. So the narrowing of networks is really, I think, a new reality within our space.
Do you see any, whether it's sort of large employers or, even some welfare funds actually going and creating sort of captive providers in that regard? Or do you see that as a market that, would that actually happen?
There's trying to think of how we might think of that. The appetite is not limited to a size of the market or a segment of the market. You get the same answer from a 5-life group as you do from a 1,500 life group or a 30,000 life group. They want quality and they want it at the best available rate, and that balancing act is, it means different things for each of them around how they position their benefit offerings, but at the end of the day, it really comes back down to quality and efficiency.
Hey, Gary, any predictions or trends that you see in the marketplace over the next sort of 2 to 3 years or 5 years?
Yeah, I guess I'll take the inverse of their position,
Yeah.
since I've seen this before. I think we have to remember, as health plan people, our goal is to help the employers attract and retain the best employees they can. That's where they're offering benefits. And so I get the current economic pressures we're in. We're in, I would say, depression, so I get it. But I think we're going to come out of that. Obviously, we're going to come out of it. And the fundamental challenge you always have is how do you balance the economics on choice? And I guess I would, again, to the other panel, agree with them. I don't think healthcare is all that local anymore. If this was a conference on newspapers 20 years ago, newspaper panel say, yeah, it's a local business. I don't subscribe to any local newspapers. I read the Financial Times. I mean, in fact, our local paper in San Francisco has gone away. And so I think it's a combination, yeah, for certain non-acute care, yeah, I think it is a local setting. You know, I got a sore throat or I have whatever, pink eye, you know, things of that nature. But, you know, if there's something I think specialized, something high-end, I don't think it's a local decision anymore. I think you're starting to see some employers that are self-insured. It's cheaper to get their employees on an airplane and fly up to Swedish Medical Center up in Seattle than have the care rendered at UC San Francisco.
Do you see that trend going international?
Yeah, I do too. You know, I'll tell you, the company I was running, the CRO, 2/3 of the drugs you're taking probably weren't tested in the United States because you couldn't find the patients. They're too expensive and difficult to find. And so my entire company was outside the U.S., you know, to find clinically naive patients that weren't taking something else. And so I think healthcare is now a global market. It's, to call it local, I think, is like the newspaper industry.
Craig, any response?
Well, I mean, you know, I guess I look over the last few years and you know, see the whole medical tourism piece, you know, whether it's, you know, domestic or abroad, you know, everybody sort of jumped on that wagon and thought this was going to be a big trend, but I'm not sure we've seen as much of that as we expected to. And I mean, I have several colleagues of mine, frankly, who, you know, jumped from, you know, stable blue plan jobs to, you know, a couple, you know, companies like that. And, you know, now they're back at Blues or other, you know, health plans.
It's nice that you bring them back home.
Yeah, so it's, you know, we always come back. So I'm not as, you know, you look and say, you know, it seems like there's this great business case to do it, but, you know, you end up getting into logistics and a lot of, you know, concerns about quality that I think, you know, scare a lot of people off still.
Tom, is that your experience as well?
Yeah, there's a I would still define it as a niche. It's not gotten any heavy adoption. There's still a need for it, from the need being defined as people believe that is something they want to do, and there are some firms in that space doing it effectively. It's not, I don't think it's ever going to grow to be anything of scale, and but it still continues to make incremental sort of penetration into this big system that we have.
I guess one thing I would say is, I mean, that could begin to change that dynamic is as you get members and patients more connected into the cost of the care that they're receiving, you know, and they understand what the price is and what their options are to have that, you know, in real, you know, where there's a recognition that says, you know, at Northwestern it's going to cost me $10,000, and over, you know, if I fly up to Swedish Medical, it's going to cost me, you know, $5,000, and I'm at a point where I, you know, with my HRA and my type of coverage where I've got a lot more skin in the game, you know, then you might begin to see some influence on that. But, you know, that all starts with transparency and understanding and having members connected into that cost structure, and knowing what the costs are at the different locations and places, and you know, tied in obviously with the quality as well.
Yeah, I think in my opinion, what's changed is the internet. I mean, it's to let the genie out of the bottle. I mean, there's no longer, do you go to your primary care physician and they're, you know, they're basically at the front and center for all your medical knowledge. I mean, before I go to the physician, if I have something, I'm reading, I'm sure you're smiling too, because I'm walking their arm with a bunch of, yeah, noodling on things.
Well, there's both the consumer access to information, but also information that you are investing in and making available, whether it's preventative care or outcomes-based measurement or case management, that in addition to the direct consumer access to information, that I think you are all sort of working on the technology piece to make sort of both better outcomes and better informed decisions. And then how, in terms of your investment, you know, in that technology and in the information sharing and in that case management, what do you see sort of where you're at now and where do you expect to be?
Let me give you a kind of thesis on the last company. I think one of the issues, I think clearly the consumers need that information. Both gentlemen and their organizations are working on it. I know his is because we helped them. I think one of the fundamental challenges in healthcare analytics is not a technology problem. I say that people like, it's a data set problem. And when I say that is until you holistically bring, at Tom's level, all his medical information together, and you can study it in one central spot, at a patient level, that's the next generation analytics. And I know they're spending time and money on that. And I would imagine you guys are too. But I think right now, we're doing these one-off solutions that are in the market now, which are interesting. But I think the real value is that bringing that patient-centric data set together and using that as the next generation for outcomes, quality indicators, things of that nature.
And you see the payers really being the drivers of, I mean, that's a huge investment cost.
Yeah, I think the only people that have the scale and the funds to do this are the payers, unless the government steps in, but I don't think we want to do that.
It's expensive. Tom, any reaction on your end?
We've built, for over 20 years, have had a focus on data. One of our platforms, our main platform for that is a company formerly known as Ingenix. It's now known as Optum Insight. And we've been collecting and storing, manipulating, and sharing that data for the better part of 20 years around everything that Gary's talking about. It's trying to identify. It's not a case of just, wow, we have a lot of data. What do we do with it? How do we make it actionable? How do we make it meaningful at the individual level? So there's a personalization that has to take place to synchronize all that data around the individual to help him or her know their own health, help facilitate that with their physician, and to make the trajectory much more predictable. There's countless examples of how that can be done and how it produces those outcomes that we're looking for. But the idea of population management is a relic of the past. It's about, if you ask yourself what's the most important, whose health is the most important, it starts with you. Your priorities are probably, when you list them on a daily basis, your personal health isn't the first one, but when it fails, it becomes your first one. And you want it to be restored and repaired as quickly as possible. And so we believe our role is to be able to pull all that disparate data around the individual and synchronize it in a way that helps you, and that it doesn't always result or come from a reactionary posture. And there's a whole business that we've built around this, and we're very committed to this going forward, because it is something that we believe is going to help combine things like chart reviews that were talked about by Gary. Those are things that have to continue to evolve, and so we're extremely committed to it. Technology investments in our enterprise are on an annual basis over $250 million, just for scale.
At this point, anything else that the panel that you wanted to discuss? Otherwise, we'll open it up for questions from the audience. Anything we missed? All right. Any questions? Yes.
This issue of analytics and healthcare is something that was actually discussed in another session. I know it's a big focus of payers. If payers are going to be central repository, or are becoming central repository for patient data, when patients churn from insurance companies, how are you solving for that to get to a true longitudinal record of a patient that is meaningful?
Did everybody hear the question? Yes? Okay. We're going to start with you, Craig.
This is our sidebar beforehand, so.
That is our sidebar, but I'm just the moderator.
Can I say I don't know?
Then you turn to Gary.
Yeah, I mean, I think that's, it's funny, we sort of struggle enough, I think, to try to, partner with, the provider organizations to say, okay, we've got a data set that's valuable. You heard mentioned the earlier one about, Blue Health Intelligence, which is, one of the companies that we partnered with with a group of other Blues that combines the claims data. That's one nice piece of information, but there's so much information that's contained within the provider organization that you say, we really want to begin to, collaborate and merge that together. Tom and, his company have a lot of other data as well. That's a space where I'm not really sure how you end up getting to the resolution on it. And it might be that, at some point down the road, that it's not the payer that's, the more of the center of it. But I'm not sure there's an answer just yet. And if anything, I think that's probably one of the things that you say, do you want the government to step into that space? I mean, in certain states, they've done that, where they've sort of insisted on creation of, claims databases for the state. But, I think that also scares a lot of us, too.
Yeah. Gary, any thoughts?
Sure. So, I'll give you an analog. The first country in the world to adopt the internet was France. They are now lagging as one of the countries behind internet adoption. And they took a different approach than we did. The government issued a standard and said, here's what you're going to use for standard for internet communication. And so I think the U.S. government takes a different approach. In fact, I know it takes a different approach. They did it in the internet, they did it in cell phones, they did it in a lot of technologies. They let the market build up market share, and then they come in and adopt with the market participants, create a standard. And so whether it's an EMR or data warehouses, I think once you start to see enough market share aggregation, either at the EMR level, at the company level, I think the government may come in that 5, 7, 10 years from now and say, you know what, we need to solve that fundamental problem you just articulated. And the only way to do that is have a standard API so we can exchange information independent who has the data. I think that's the way they will go. And there's other analogs in other industries where the government has done that.
Tom, any thoughts on your perspective?
Yeah, I think one of the aside from we want to serve you for the rest of your life, we believe that there's one of the missing ingredients is the individual. The individual, it's your information. Historically, you weren't even allowed to look at your chart. Like, you couldn't even see what was in that thing when the doctor walked into the, you could see it, but we were always reluctant to ask. We heard earlier about some of the problems around transparency. But I think the future, and it exists today with many of us, we all have electronic downloadable versions of your medical record. The future has to be one there where you know your information better than anybody does. And we're just playing catch up as an industry on that, because our whole mindset is not one that, again, to who's worrying about my health care, we don't always say me first. And information, medical information, as employer-based solutions can change, where you might change employers or the employer might change carriers. You have to keep that continuity somehow, and we believe we have to help keep continuing to create those solutions that you can download them onto a USB encrypted device, or you save them to some other solution that is yours, and that all those other nuances of where you work and who your insurance is become secondary.
Let me give you some legal tidbit, because we tried to do this in my prior company. So we had another law firm do research on the,
I'll forgive you.
yeah, sorry about that, the 20 of the largest states around the U.S. to answer one simple question: who owns the medical record? And surprisingly, in those 20 states, it's the physician, not the patient. And as a patient, I was getting agitated. Well, go back and do it again. You're wrong. I said, Gary, we did this. I said, use the wrong law firm. Here's the answer.
Yeah, that's right. Yeah, that's right. We'll talk afterwards.
But
Gary.
the states, that do this in state laws, it's the physician who owns the record. Now, there's laws for you to get access to it, but at the end of the day, they own that data, which is kind of interesting.
We have time for one more question, and then we will break for lunch. Anything else? Yes.
One quick one, you raised a number of issues of cost level behavior among hospitals. Consumers don't really know about that. What are your thoughts on just this weird amalgam we live in where you've got for-profit, not-for-profit hospitals providing the same service? Look 10 years down the road, do you see that continue? Do you see one moving ahead of the other, and how does that relate to quality?
Did everybody hear the question? Yes? I take silence as being assent. So go ahead, Craig.
Chicago, I guess, is still such a, diverse market with such a dense population base that, you have plenty of opportunity to support a variety of organizations out there. I do think you're going to, start seeing, a larger push on transparency and insistence on that. From our perspective, we'd say, groups like AMA and others have sort of stonewalled on some of that stuff, behind a lot of issues. And, there's some, valid issues they raise, certainly. But, you've got to move to that type of space where, consumers can know it. And I think at some point that begins, to say, for those hospitals and provider organizations that aren't, at the kind of cost point or quality point, that they've got to begin to implement changes and fixes to that, to be able to stay competitive, which they haven't had to do in some ways in the past. And if they don't, then they're going to run the risk of, the networks that we're going to create are going to completely exclude them. And as you have more and more employers moving folks and targeting them into networks where they're not part of it, it's going to become more and more detrimental to them.
Any other thoughts from our panelists?
The financial realities in the hospital space are one that, there are mergers being done now that we would have never thought about, especially in Chicago. You've now got for-profits moving in. You've got marriages that are being made, some strategic, some out of necessity to shore up balance sheets, and really that's a reality of 5 out of every 10 patients that come through the door are a form of government payer. Medicare, which is underfunded, and Medicaid, which is woefully underfunded. You might even call it unfunded. And then the charity care that's delivered. There's a real economic pressure that these alliances that are being formed are really just now necessities, whereas they weren't 5 years ago, 10 years ago.
All right. Well, thank you to our panelists. We're going to break for lunch. Lunch is back in the ballroom where we were originally this morning, and thank you. Good job.